all 3 maritime provinces, with teams based in New Brunswick, Nova Scotia, and Prince Edward Island. My name is Rachel Giacomo-Antonio, and I'm the Knowledge Translation Coordinator with the MSSU, and I'll be your host this afternoon. Before I go any further, I'd like to offer a land acknowledgement that reflects my location in Jabuktuk, or Halifax. I would like to acknowledge that I'm in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendships, which Mi'kmaq and Wolastoqiyik people first signed with the British Crown in 1725. The treaties did not deal with the surrender of lands and resources, but in fact recognized Mi'kmaq and Wolastoqiyik title and established the rules for what was to be an ongoing relationship between nations. We are all treaty people. We are committed to developing authentic and meaningful relationships with Indigenous communities and supporting the inclusion of diverse perspectives in healthcare research across the Maritimes. And as a part of that commitment, we also recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for the last 400 years. So today's session focuses on citizen-driven research into supports for older people to live in the community when they have complex health and social care needs. This work is brokered through a unique SPORE Evidence Alliance initiative that pairs citizens and researchers to address citizen priority questions. And Shelley, if I can get you to move forward one slide. Oh, maybe she's not there. There we go. Just a few housekeeping notes before we get started. So please mute your microphones. We are recording this, so it will be available online to watch later. Closed captioning is enabled for anyone that would like to turn that on in their Zoom settings. And if you have questions during the presentation, feel free to type them in the chat. If you include your name, I will call on you and you can ask yourself. If not, I will just put them to our speakers during the question and answer period. So now I'm pleased to introduce our speakers for the day. So first, Elliot Paz Jensen is a retired social worker and an advocate for older adults and age-friendly communities. She's a longtime volunteer with the Saskatoon Council on Aging and is presently engaged in research on the effects of COVID-19 on Saskatoon's older adults and on patient-oriented strategies addressing loneliness and social isolation among Canadian seniors. She has been a patient partner with the SPORE Evidence Alliance since 2017 and is co-chair of the Knowledge Translation Committee and a member of the steering committee. She is happy that her research query to the SPORE Evidence Alliance on home care versus residential care was chosen for funding and believes it has real potential for older adults who need care. Elliot is also very proud of her Nova Scotian roots. She was born and grew up in New Glasgow and is a graduate of Dalhousie University. Joining her is Dr. Elaine Moody. Elaine is an assistant professor in the School of Nursing at Dalhousie University, an affiliate scientist with Nova Scotia Health, and an associate scientist with the Maritime SPORE Support Unit. Her scholarship is focused on better understanding the context of health and healthcare for older people, particularly those with complex health and social care needs, such as those with frailty, multimorbidity, and dementia. Elaine has been a registered nurse for almost 20 years and has a clinical background in acute care, community care, and long-term residential care. Originally from Dartmouth, Elaine completed her BSCN at St. Francis Xavier and a master's and PhD at University of British Columbia in Vancouver. So our format today is going to be a little bit different. Instead of sequential presentations, Elliot and Elaine will be co-presenting their ongoing research by exploring 4 concepts that lead to systematic review. After their conversation, we'll have 25 minutes for questions and answers. So without further ado, I'll hand over to Elaine and Elliot.
Thank you. Elaine, you're on mute. Thank you for your lovely introduction, Rachel. And I would just like to acknowledge that I'm on Treaty 6 territory, the homeland of First Nations and of the Métis. I would just like to say that. So thank you very much. It's lovely to be here. And Elaine is going to introduce our talk right now.
Thank you, Elliot. Can you see my screen okay there?
Yes. Yes, we can.
Okay, thanks. Wonderful. Thank you so much for the introduction, and thank you, Elliot, for that acknowledgement of where you are. So we're here to talk today about our experience working together on a systematic review on the effectiveness of alternatives to long-term residential care for older people with complex health and social care needs. This project is unique because it was identified by a member of the public, i.e. Elliot, and through SPORE. Many of you know SPORE is a strategy for patient-oriented research, which is a CIHR program that's aimed at enabling research that reflects the realities of the people affected. They often refer to those people as patients. For our context, that didn't really work as well. So we're talking about citizen-driven research, where a citizen is someone with a vested interest in the health topic, a member of the community, a caregiver, a loved one of an older person. The Evidence Alliance is an organization that supports this type of work, and it has funded 3 reviews that are co-led by a citizen member or a patient member and an academic. So we'll tell you a little bit more about that process, including some opportunities for how members of the public can get involved in the future, coming up later in the presentation. And as Rachel already mentioned, this presentation is going to be a little bit of a different format. Elliot and I are going to go back and forth and discuss key areas of the review and why we're focusing on that area and how working together has enabled this project. So as part of this SPORE Evidence Alliance project, as I mentioned, Elliot came up with an idea. Then the projects were prioritized. There was, I think, about 10 projects, and 3 of them were funded. And Elliot's idea was chosen. Elliot then got to choose a research team to work with. And so myself and my colleagues at Dalhousie were lucky enough to be chosen. And we're really pleased to have this opportunity to work with Elliot on this project. So ready to move forward. First, I'll start off by, let's see if I can do this. Just really briefly touching on the goal of the project. We'll go through the major concepts in more detail. It is a knowledge synthesis project, so that's taking results from research across different studies, putting it together to see what the body of evidence says, which is a unique or a particular method of looking at these issues that recognizing that there's lots of other methods to do this work as well. Yes, I also want to recognize that we're a really diverse group. I know that there are people from academic backgrounds here, policy backgrounds, practice, as well as members of the community. So we really wanted to recognize that and incorporate that into how we're discussing our topics today. So we have organized our talk around 4 kind of key questions that reflect the major concepts in the review. So we'll be going through each of these questions one at a time. So more specifically, we'll talk about the population, so the people that Elliot and I are interested in supporting. We'll talk about the interventions, how we've thought about the interventions, how we've defined them, and then we'll talk about how we'd like to understand the success of the interventions, so how they work well. Finally, we'll touch a little bit more on the process that we're in for this project. And just as a kind of introduction, we are in the process of this review. We don't have findings, unfortunately, yet, but really interested in sharing this work at this point and getting feedback from all of you on the project. So with that, I'll turn it over to Elliot, who's going to talk about the group of people that we're most interested in.
Thank you, Elaine. Yes, Elaine and I both have a really special interest in older adults who are vulnerable, socially isolated, frail, and on the cusp of having to leave their homes and move into long-term care. So the population of our study is that of older adults, people who are 60 and above, who live in the community and who have a number of health problems, two at least, often more than two, and they're very vulnerable to having more. They are experiencing functional decline. That means they're not able to do some of the activities that are required just to live a day, or longer, of course. So as they lose, and they're vulnerable to losing more too. Now, as they lose abilities to do things like shop for themselves or cook for themselves or get dressed or toilet, they need someone to help them. And some of the older adults have no one. Others have some people and a little bit of support. Others have a lot of support. But even those with the most support, that support can wane over time. Caregivers are not immune to having health problems themselves. They usually have other demands on their time and energy from other family members, from earning a living, for all sorts of very important things. And we know that caregiving itself takes a toll on people. So that over time, what happens is that these older adults need help more than what their family, their neighbors, and their friends can give them. They need something else. So I will turn it over to you, Helene. Segue to talk about interventions.
Yeah, so in terms of thinking about how we can support people with complex needs, health and social needs, we've taken a perspective of a citizen. That has been really one of the unique things about this project. Is working with Elliot has meant that we are taking the perspective of a member of the public. So in terms of the intervention, what has this meant? It means that we want to capture what's important to older people as they age, in terms of an intervention to keep them at home in their communities where they'd like to be. So more specifically, it means that we're going to look at interventions that aren't solely focused on healthcare. So from the perspective of a community member, there really aren't the silos that we have in healthcare and social care. They don't see things being separated into primary care, specialist care, community care, private supports through home care or meal support, that type of thing. It really is just the support they need to carry on with their daily life. So we're looking at wraparound services, wraparound interventions, or complex interventions that cover multiple sectors, multiple types of support. Also from this perspective, we're recognizing that there's a great deal of diversity, even within this group of older people with complex health and social needs. Older people have various life experiences. They have various experiences with the health conditions that they're living with, as well as their social support network. So in that sense, we're looking at interventions that focus on individualized care. So looking specifically at the person and what they need in an individualized manner. So really, the interventions that we're focusing on for this review are complex interventions that cover services and supports across sectors and are individualized to the person and their families. So Elliot will now talk about her approach to how we understand the success of these interventions.
When Elaine came up with the idea of looking at the effectiveness of alternatives to institutionalization, I just felt this was a eureka moment for me. I felt it really got to the heart of my concerns. It got to the heart of the issue. My topic, I did not have to submit a research question structured in a research fashion to the Explore Evidence Alliance. That was not required of us and really is well beyond my level of abilities. So how my question ended up being structured for the Alliance was residential care or nursing home care rather for older adults versus at-home care. And it grew out of my work as a social worker in geriatrics for many, many years, and also personal experience too, where I found that many older adults had to go into special care homes, even though they didn't want to. They had to move out of their homes if they were going to get the care they needed to get through the day. And I just really felt that in many instances, it really wasn't warranted. If there were services available, they would have been able to stay at home. And when Elaine came up with the idea of effectiveness, why it was a eureka moment for me was, you can compare the two types of the two locations of care, and it's an academic exercise. But what really matters to older adults, what really will make a difference, is if those alternatives are effective. If they're not effective, they're no good. But if they are effective, they have the potential to make a real difference in the lives of older adults and actually to the health system as well. Yeah, it just was. I just thought that Elaine got to the heart of what I wanted, and I couldn't put into terms myself. I'm terribly appreciative.
Thank you, Elliot. And from my perspective, really working with Elliot on this and really thinking through these kind of academic questions from the perspective of a community member has led us to think about outcomes and effectiveness a little bit differently. Quite often when we are working on reviews, we think about health system outcomes. We're taking more of a societal perspective or a public perspective. So we've really embraced an individual perspective on the outcomes we're looking at. It will probably be no surprise that there's a lot of overlap in these. So for example, we're looking at health system outcomes. Being admitted to hospital, seeing a family physician, being admitted to long-term care, but we're also looking at quality of life outcomes. So really thinking about if we're supporting people in the community at home, is it a place where they'll continue to have quality of life? So that is one of the things that's really important to the review as well, and one of the primary outcomes we're looking at. So finally, we'll touch on the process a little bit. Ellie will start talking about her experience coming into this project, and I can touch on kind of the more academic part of the process.
Okay, yes. So what are we as co-leads, a researcher co-lead, and a citizen partner co-lead? What are we doing differently in this project on a citizen-driven issue? How are we going about co-designing this research process, working together as partners in an open and collaborative way, in a way that's meaningful to both of us? So we're learning as we go, and from our work to date, we've come up with 4 principles that guide our work, how we work together. The first is appreciating what each person brings to the project. The researcher, of course, all the multiple research skills, the citizen partner lived experience that is often accompanied by an emotional overlay, which we can talk about later, and the voice. As an older adult myself, I bring the voice of the group most impacted by the findings of the research. The second is making space to build trust. The initial meetings of the co-leads and of the team, the whole team, set the foundation for relationships and for building trust, or not. As citizen partner in a role that was beyond my comfort zone, I cannot emphasize enough how important these meetings were for me in helping me gain trust. In our initial co-leads meeting, I found Elaine to be very committed to getting to the issues that were most important to me and to honoring my vision. In the initial team meeting, I observed a researcher concerned her comments were too critical, and the response that such comments are constructive and therefore welcome. I observed that the perspectives of the 5 citizen partners present were sought. it really spoke to me of a safe, welcoming, respectful environment. Building trust, however, is not accomplished in 1 or 2 meetings. It's ongoing and takes commitment to continue the work of that. The third one is enabling open communication. And of course, without open communication, you can't show that you appreciate what the other person brings to the project, and you can't make the space to build trust. Enabling open communication is very important, and it is the responsibility of both co-leads to foster open communication between ourselves and within the whole team. We're committed to following good communication practices, not only in terms of the nuts and bolts, such as using plain language and having agendas for meetings, but in such practices as listening actively, curiously about another's perspective and trying to get to what's important to them, just as Elaine did in the first meeting I described to you. And the fourth is acknowledging differences, which of course is not possible without the other 3. It is important to have diversity of experience and perspective, because well explored and incorporated into the research helps identify gaps and priorities. It adds breadth and depth to the research, making it more inclusive and increasing its relevance to those most affected by its findings. So I'll turn it over to you, Elaine.
Thanks, Elliot. In terms of the systematic review, we're currently screening over 24,000 titles and abstracts. I think given the nature of this project and how we're defining our population, we did have a large body of results that we're reading through. We have a good group that is working on that. But if anyone would like to join the team and help us with screening, we would welcome any volunteers. We're also thinking about how we're going to disseminate the findings, how we're going to share these findings with different stakeholders. So we'd be really interested to hearing any of your thoughts on that. And finally, we're hoping to have our findings in early in the new year, and would really like an opportunity to share them with you all any way possible. So I think Rachel has offered to send out an evaluation at the end, along with gathering some information from any of the participants here today. If you'd like to hear about the findings of the review, we'd be really interested to hear from you. And then the last piece, Elliot, I think you were going to talk about this as well. We mentioned a bit about the Spore Evidence Alliance and how they're funding our project through the citizen identified issues that was then prioritized and partnered up with a research team. Sorry, and Elliot, did you want to share a bit about the future opportunities?
Oh, sure. Yes, this is the first time that this has been done, apparently, that there are 3 research projects being undertaken in this fashion. And CIHR has funded the Spore Evidence Alliance to fund 10 for this next year and 10 for the following year. So that's 20 more projects that will be done that way. And so I really would encourage you, if you have an idea yourself, it doesn't have to be presented as a research topic. You can see how far away mine was removed from what a research topic was, and how a research was able to bring it in a way that is not expected of those of us who are not researchers. And so I really encourage you to move forward. And if anybody here who is a researcher knows someone with a good idea, please encourage them, because actually it was a couple of researchers not involved in this project who really encouraged me to, put forward this topic. Yes. So, and you see that it's up on the screen. If you go to the Spore Evidence Alliance website, there's a lot of information there about the projects that are being funded right now, and it tells you how to submit a request. And there's space there for researchers, and there's definite space for, and within the islands, they're called patient. You won't see citizen partner, you'll see patient or member of the public partner. So I encourage you to do it. Thank you.
Great. Thank you, Elaine and Elliot, for sharing your project with us today. And it was fascinating to see how the research has developed so far, how it's continuing to develop, and really interesting to see how your involvement, Elliot, both with proposing the topic and then working together with Elaine, sort of transformed the focus of the research. And that's maybe something that's a little bit unusual in the evidence synthesis world. So nice to see that collaboration. And you certainly hit on something with your topic, Elliot. This was a very popular session. So we'd like to open it up to questions to the audience now. Just as a reminder, you can drop questions in the chat and include your name if you'd like to ask them yourself, and I can call on you, or I can put questions to the speakers. We do have one question in the chat right now. Elliot and Elaine, it says, which tool are you using to screen participants? So I'm not sure whether that's participants or maybe the papers that you're using in the review. I don't know if the person asking wants to clarify, or if you have an idea, Elaine.
Sure. Yeah, so it'd be great to hear from whoever asked the question. I'll address it how I'm interpreting it, but I might get it wrong. Oh, someone popped up. Is this?
Oh, hi. Can you see me? It's Karen Nichols. Hi, hi everyone. Great topic. I work with the Frailty and Elder Care Network out of Nova Scotia Health Authority with Dr. Ken Rockwood. Question on how you're assessing your participants' frailty, whether it be social, economic, and so on, because really frailty is the umbrella of all those complex and social needs. So how are you assessing each patient, or not patient, community member?
Yeah,
to
so
determine what their needs are, whether they be social or health.
Yeah, that's a really, really great question, and something that we've been thinking a lot about. I was just writing about that today in our protocol, and looking at Dr. Rockwood's work on frailty and how we're kind of conceptualizing it. It has been difficult because of the population we're interested in. And obviously with frailty, it's been a challenge kind of having that operational definition. It's a literature review, so each of the research studies will have used likely a different method of identifying the participants that would be relevant. Not all of them would use a frailty measure specifically. So we are using a kind of a really broad net to see what we can find. So we're looking at people that have either multiple chronic conditions or significant functional impairment and require ongoing support with our activities of daily living.
So I'm in acute care, and we'll eventually expand to community, primary care, and so on. We have determined that the clinical frailty scale is the most validated tool worldwide. I think, they've had over 1,000 research studies on the clinical frailty scale itself. So that's what we have determined to use at a provincial level. Within acute care and wherever else we scale and spread, we will be using the clinical frailty scale to determine. And, I think people find the word frailty offensive, but it's not, it's really helps us determine, especially in the hospital course, where the patient is and what we need to build on from a resource perspective to be able to get them home. Like, do they need more rehab? Do they need, social support? So it kind of allows us to determine economic frailty, social frailty, as well as health frailty. But yeah, I'll be interested to see what tool you determine that you will use.
Yeah, absolutely. And that's a really important point about the use of a tool to identify people that are frail. And obviously the Frailty Index is very important for that.
Well, because it captures all patients, not just frail. I mean, 1, 2, and 3 are those who are very mobile, up moving around and living their lives. They have no problems with IADLs or ADLs whatsoever. So it, it does capture that broad view. And it does, I know within the initiatives that we're offering, it does allow us to develop individualized care pathways and planning based on a person's frailty level.
Mhm.
So if you're
That's
ever interested
wonderful,
in seeing
Karen.
what we're doing, we're happy
Yes.
to
I
share.
am doing research on dementia care in the hospital. I would love to talk with you about about your work. So please,
I'll put my email in the chat.
yes, do. Yes, it would be.
Yeah,
wonderful
I'd be
Thank
happy
you.
to share all of our work that we're doing. Great, thank you.
Great. Thank
It's
you.
a great connection made. And Elaine, to your point about casting a net wide during the evidence synthesis, it'll be interesting to see how many of those sort of 24,000 hits you have in the initial screen are using maybe that measure or another measure of frailty, just to get a sense of how common those tools are and in which areas of the world and so on.
Yeah, and of course, frailty is a relatively new concept that's being used, and we're looking at interventions from kind of the from way back. So it might not even be a term that was used and really hasn't been well taken up in the literature still. I think it's definitely coming to be used more often, and I think in the literature people are seeing the value of it, but it has been.
We tend to be a little further behind in Canada, but if you look at what the world is doing, Australia, UK, the Netherlands, Spain, Mexico, major countries, it's now, the UK, a patient doesn't have a contact with any piece of the healthcare system or community teams without having their frailty scale scored. So we tend to be a little further behind in Canada, but it's utilized around the world.
Very interesting.
It's their main tool.
Great.
Okay. Well, thank you. I stuck my email in.
Perfect. We have another question in the chat from Wendy. She was wondering, have you defined complex health and social care needs? I think this goes back to your point just now, Elaine, about how the language itself can sometimes be not precisely defined or differently defined.
Thank you, Wendy, for that question. I can let Elliot answer some of these too. Sorry, I'm taking on.
Well, this is research, and I'm happy to be listening in.
And really, these operational definitions have been difficult.
Yes,
because the literature has really focused on defining things a particular way, and it doesn't align with how we're thinking of the issues from the perspective of the public. So complex health and social care needs. So we're looking partly at the population. So that's people that either have multiple chronic conditions or have significant functional impairments that requires ongoing support. And then we're also looking at, so that's kind of, I think that's the health and social care needs. And the other piece in relation to complex is that their needs span what we would consider different sectors or different aspects of care. So across private or public, across healthcare, and then social care, or municipal community resources, what we think of in Nova Scotia as private or nonprofit services. So really looking at, a good example would be like case management. When you have an older person who is coming out of the hospital and really doesn't want to go to long-term care, they want to be set up at home. So you have some sort of case manager who's looking at exactly what do they need in the community. Maybe they're in a rural community, they need to have someone to come and plow the driveway to make sure the home care workers can come in. So it is finding those multiple services that will support kind of wraparound needs of the individual and that are unique to their particular situation. So I hope that's answering your question.
And I see Wendy has her hand up. Wendy, did you want to come in for a follow-up there? Oh, she's disappeared from my screen. So Wendy, if you want to join in, just put your hand up again and I'll call on you. I think in the meantime, Elliot, I was curious. I know you said we're sort of discussing.
Wendy's hand is up.
Oh, her hand's back up. Okay, Wendy, over to you. Or I wonder if we're having audio issues. Yeah, I see muting and unmuting. Wendy, if you're having trouble speaking, you could put it in the chat and I can read out for you. No.
Or we can connect another time, Wendy. I haven't seen you in a while, so it'd be good to chat.
While Wendy's kind of typing or reaching out, Elliot, I know you had said that it's sort of a research issue around some of the terminology and how we look for them, but I would be curious to hear your thoughts on how that definition is coming together and evolving with complex health and social care needs, and really what that kind of overlap between sectors means just as an older adult trying to interface with those types of services.
Perhaps I'll start off by saying that I've been surprised by how some of the research really has looked only at, when they're looking at factors that tip the balance, the scale into long-term care, they often only look at trips to emergency, number of visits to the family doctor, or nurse visits, or whatever. They don't look at the non-medical needs, which make a huge difference. I mean, and that has been an issue here in Saskatchewan, in terms of getting the driveway plowed, that people have seem to be resistant to giving that kind of help, and it is absolutely essential if people are going to stay at home. Yes, so I think that I've been very interested in this discussion because as somebody who is trying to use COVID and trying to see whether a study applies or not, I too have real trouble sometimes figuring out, is the intervention, how complex is it? And the care needs are often really not defined in terms of beyond the medical. So it's been fascinating to me as a member of the lay public to be reading all of this, and having been a social worker, for years and years in geriatrics as well. So I'm on a steep learning curve.
I think the point that you're making relates to something that we'd spoken about too, around that kind of shift when you were looking at the kind of efficacy and so on from a population level to an individual level. And I know you touched on that a little bit in the talk, but I think looking ahead to what sorts of things you expect to come out of the systematic review, maybe you could talk a little bit more about how you think or what information you'll find about that efficacy of these services, what we might be able to learn from that analysis.
Well, having been an advocate most of my life and still am, I think what I've been learning is that I need to wait and see what the findings are, and that my preconceived ideas may not be right. They may not be valid. And I think that if we're really interested in evidence-based change, then I have to wait and see what the evidence is. And so this is one of the learning paths that I've been on, trying to switch gears from being an advocate to being involved in research and saying, okay, well, let's see what happens. I am excited to see what turns out. And one of the things that so appealed to me about the team, Elaine was saying how glad she was that I chose her team, and I'm so glad too. And one of the strengths that I really saw was that they had many of the researchers on the team, well, they had extensive experience in research in the areas, both of home care and residential care. But they also many of them had clinical experience. And on the team also, there was a member of the Nova Scotia Health Department, a senior member. And I thought, aha, somebody may be interested in taking these and doing something. There's a real potential here for this not to sit on the shelf, but to be utilized. And that really, really appealed to me, as did the fact that there were 5 citizen partners who were all set and ready to go too. So I have set aside my preconceived ideas of what I expect to get out of this. I'm really looking forward to seeing what does come out of it, and then working with other people, or with the researchers, and maybe some people here too, in seeing what can we do to move things along.
Great, thanks, Elliot.
I
Who's here for the follow-up? Elaine, you want to weigh in?
Well, I think that's great. And I think that's one of the real strong values of having this project co-led by a citizen member, is looking at the advocacy piece. And I don't know how much we talked about the other patient partners. We have another group of 5